of PMA. And before starting today's program, an introduction of worthy guests, I will request Professor Rashid Saab to recite the Holy Quran.
Jazakallah, sir. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم قل تعالوا أتل ما حرم ربكم عليكم ألا تشركوا به شيئا وبالوالدين إحسانا ولا تقتلوا أولادكم من إملاق نحن نرزقكم وإياكم। ये सूरतुल अनाम की आयत 151 थी। इसका मफ़हूमी तर्जुमा है, उनसे कहो कि आओ मैं तुम्हें पढ़कर सुनाऊं कि तुम्हारे परवरदिगार ने दर हकीकत तुम पर कौन सी बातें हराम की हैं। वो ये हैं कि उसके साथ किसी को शरीक ना ठहराओ और माँ बाप
राशिद साहब आवाज नहीं आ रही आपकी।
जी मुझे भी नहीं आ रही।
नहीं, तिलावत तो हो चुकी है कि
ओके,
तर्जुमे में
थैंक यू सो मच।
इंटरप्ट हो गया।
दरमियान में कट
तिलावत की
गया।
आवाज नहीं आई।
चलें, अच्छा, थैंक यू सो मच राशिद साहब। टुडे इम्पोर्टेंट इंट्रोडक्शन ऑफ प्रोफेसर सफदर।
छोड़ो भी पढ़ लो पहले।
बेटा आप वदीद इनको ऑफ कर दें। डॉक्टर फरजाना अब्बास साहब ज़रा म्यूट कर दें अपनी, उसको आवाज़ आ रही। टुडे आवर स्पीकर इज़ प्रोफेसर डॉक्टर सफदर मलिक. He is a graduate of from KE, almost 3 years senior to me, and then he did the TMRD and then post graduation in radiology. And very long introduction of Professor Safdar Malik. एक खूबसूरत बात जो है, he spent a lot of time in Fatma Jana Medical College and Mayo Hospital, and almost he has presented 350 national and international paper, almost 50 articles in different national and international journals, almost 300 cases of treated and FRA. Al-Noor, इसके बाद इन्होंने मेरे सामने देखते देखते एक कमरे से इन्होंने एक अल-नूर हॉस्पिटल शुरू किया। आज माशाल्लाह एक अल-नूर इंस्टीट्यूट्स हैं, एक बहुत बड़ा, जहाँ पे उसके अंदर पोस्ट ग्रेजुएशन के अलावा भी अंडर ग्रेजुएट भी इन्होंने मुख्तलिफ कोर्सेज शुरू किए हुए हैं। इसके बाद इन्होंने ही इज़ फर्स्ट इन पाकिस्तान इन 2004 टू स्टार्ट 3D 4D अल्ट्रासाउंड, स्पेशली गायनेकोलॉजी एंड ऑब्स्टेट्रिक। हम आपसे एक गुजारिश ये भी करेंगे कि यू आर नोन द अल्ट्रासोनोलॉजिस्ट ऑफ गायनेकोलॉजिस्ट एंड ऑब्स्टेट्रिशियंस। इंशाल्लाह most of the diagnosis you have already done, and especially my family doctor, even whenever I feel myself any problem, I go to Professor Safdar Malik. आज के प्रोग्राम का ये था, स्टार्ट इसलिए किया था कि 24 तारीख को प्रोफेसर इकबाल डोगर साहब ने एक बहुत रंगारंग प्रोग्राम बनाया, और जिसको जेम कॉन के हिसाब से दुनिया के नेशनल और इंटरनेशनल लोगों को बुलाया, और उसमें एक रेडियोलॉजी का सेशन भी था, बहुत खूबसूरत सेशन था। तो प्रोफेसर इकबाल डोगर साहब प्रिंसिपल हैं गुजरावाला मेडिकल कॉलेज के, और इस तरह के प्रोग्राम करते हैं। आज के वो चीफ गेस्ट हैं, मैं वेलकम करता हूँ प्रोफेसर इकबाल डोगर साहब। और इससे पहले कि हम इसको स्टार्ट करें, मुझे याद है कि पंजाब मेडिकल कॉलेज PMC गुजरावाला फैसलाबाद में मैं हेड ऑफ द डिपार्टमेंट था 2015 में। तो एक हमारी एक महफ़िल शाम हुई थी। अक्सर मुझे महफ़िल शाम का मतलब है शाम गज़ल उसको कहा जाता था। तो आज मैं उसकी याददाश्त को खोल रहा था, देख तो फेसबुक पे वो नज़र आ गई। तो मैंने कहा उसको स्टार्ट करने से पहले दो उसके शेर हैं वो खूबसूरत आपको स्टार्ट कर दूं। मैं दश्त दश्त रुस्वा तू शराब सा मुसलसल, मैं दश्त दश्त रुस्वा तू शराब सा मुसलसल, मैं लम्हा लम्हा तन्हा तू ख्वाब सा मुसलसल, मशहूर है नगर में मेरी तशनगी के किस्से, हैं करिया मैं करिया करिया प्यासा तू आप सा मुसलसल, मैं अक्स आशनाई तू सरापा दिल लगी है, मैं खार खार जिंदगी तू गुलाब सा मुसलसल, मैं गली गली मुसाफिर तेरे कुर्ब का दीवाना, मैं कूचा कूचा बिखरा तू नायाब सा मुसलसल। आखिरी शेर बहुत अच्छा है। ओवर टू यू प्रोफेसर सफदर मलिक साहब टू स्टार्ट टुडेज प्रोग्राम।
जी बिस्मिल्लाह रहमान रहीम। प्रोफेसर मुलाज़ बुखारी साहब, आई होप यू कैन हियर मी। आपको आवाज आ रही बुखारी साहब?
जी बिल्कुल आ रही सर, बिल्कुल आ रही सर।
वदीद फिर कुछ ग्लिच आ गई है, आवाज नहीं आ रही।
जी आवाज आ रही बुखारी साहब भैया?
आ रही है, आ रही है, आ रही है मैडम, आ रही है, आवाज आ रही है।
आ रही है।
बिस्मिल्लाह रहमान रहीम। अस्सलाम वालेकुम टू ऑल माय कोलीग्स। सबसे पहले बुखारी साहब आपका बहुत शुक्रिया फॉर वेरी स्वीट एंड काइंड वर्ड्स टू स्पीक फॉर मी, एंड इट्स माय प्लेजर एंड माय ऑनर कि लास्ट संडे इकट्ठे थे वहाँ पे गुजरात में। तो आपने भी मेरी प्रेजेंटेशन देखी, तो आपने हुक्म दिया कि अगले संडे को आप भी हमारे फोरम पे भी ये डिस्कस करना। नो डाउट मेरा ज़्यादा इंट्रोडक्शन जैसे आपने बताया कि गायनियोस के साथ है, लेकिन पूरी ह्यूमन बॉडी को जहाँ तक हो सके मैं अपनी कोशिश नातवा करता हूँ कि मैं कुछ ना कुछ उसमें भी कंट्रीब्यूट करूँ। आज मेरी एक हम्बल सी प्रेजेंटेशन होगी आपके सामने कि रोल ऑफ इमेजिंग स्पेशली विद रेफरेंस टू द पीडियाट्रिक एब्डोमिनल emergency. That's my topic today. I'm going to share with you. First of all, importance of prompt diagnosis in pediatric abdominal emergencies. Why ultrasound is required? एक तो ये कि जो हम इंटरयूटेराइन फीटल abnormalities देखते हैं like ovarian cyst and duplication cyst or any other pathology, they can be verified immediately after delivery by the ultrasound. And the probe which we need normally is a high resolution because the babies are very.
आवाज बहुत कम है, अगर जरा ऊंचा बोल सकते हैं तो।
अच्छा जी, मैं ऊंची बोलता हूँ।
अफ्तर साहब, मलिक साहब जरा थोड़ा सा माइक आगे कर लें, आवाज कम आ रही है।
माइक मैंने कानों पर लगाया, होप आई शुड बी ऑडिबल। जी मैं ऊंची बोल लेता हूँ थोड़ा सा जी। अब आवाज आ रही है जी? इज इट बेटर नाउ?
जी, इट्स बेटर।
यस।
अच्छा, थैंक यू वेरी मच। First of all those intrauterine pathologies we look for on ultrasound or static scan, they can be verified immediately after delivery to avoid any complications for the future like ovarian cyst, duplication cyst, or any other pathology. Other than that, in case of diagnostic reasons, we use and prefer to have the ultrasound because it's very high resolution. It's harmonic and panoramic imaging. The use of color Doppler, and it's a dynamic assessment. Other than that, it doesn't have any radiation. It's a bedside facility available, and there is normally don't need any sedation in this patient because mother can feed the child and we can do the ultrasound. So the baby remains quiet with the close contact with the mother. And there's no contrast allergy as we have to give the contrast IV in case of it. And baby handling is difficult for imaging. But that doesn't mean we don't need the CT or X-ray. In case where we find the difficulty or in case where we need the support of other modalities, they always should be used. But I think ultrasound should be used as a screening tool as well as a diagnostic tool to start with any pediatric abdominal complaints. There are certain limitations of the ultrasound. Number one, it's always operator dependent. I always say buy a good ultrasound machine with color Doppler. Sometimes back when I started color Doppler, some people said it's maybe little waste since 1989, 19. But I think there should not be any ultrasound machine without color Doppler. As you will see its indication, it takes 1 second to switch it on, but makes life much comfortable, especially if you are looking for any pathology which is in relation with the blood vessel and that's going to share with you. So good machine will also help you out, but make sure it's not the person behind it. So operator dependent very much. So you've got a good skill of it. You can do a lot of help to the patient. Bowel gases, they do sometimes come in your way, but to avoid that bowel gases, we use gradual and gentle abdominal compression to displace the gut loops, because babies have got not that distant gut loops as the elders are, and the skin is very thin, so you can safely, slightly compression ke saath, you can appreciate this underlying pathology with ultrasound. Here I will point out for the youngsters that age of the baby is very important. Number one, more history, please, history, always say history of the baby is very important. But there are certain pathologies which are related to the age. If the baby is less than 2 years, keep in mind necrotizing enterocolitis, hypertrophic pyelocinosis, which comes around 4 to 6 weeks. There is non-bilious vomiting of the baby. And if there is upper GI obstruction you're suspecting, then there's bilious emesis, maybe midgut valvulus or intestinal malrotation. But if there's low GI obstruction you're suspecting, like interception, then current GI stools is the classical sign, symptom of the babies. Similarly, between 2 to 5 years of age, when the baby is the preschool age.
Sorry, Professor Safdar साहब, वॉल्यूम बहुत कम है, थोड़ा सा वॉल्यूम ऊंचा कर दीजिएगा.
ओके, मैंने वॉल्यूम तो पूरा है, असल में अपनी आवाज दोबारा इंक्रीज करता हूँ. लेट मी try to give you better voice. In a preschool child who is 2 and 5 years old, the diagnostic pathology we should look for is interception. There is a thought that every child has got acute appendix. But let me share with you, if your baby is 2 to 5 years old, please first give priority to the interception. Second is appendicitis. Third is intestinal malrotation, volvulus. And always never forget that hepatitis is one of the. So that's why the history of the patient is very, very important. How is the history presenting baby? Similarly, if you go from 5 to 12 years of age, the volvulus. And if you find a child who is 12 years old and appendicitis, testicular or ovarian torsions, and gynecological conditions in female patients, dysmenorrhea when the girl starts having menarche, because sometimes the girls, you know, they start periods earlier, so they may have dysmenorrhea, and look for the cause of dysmenorrhea. She might have some ovarian pathology. And if they have got amenorrhea, please, very important, the patient complaints are cyclic pain. Every time month, and she's going to have the period, she gets pain, but there's no period. So think of imperfect hymen, because the baby is having, but it's accumulating in the vagina and not coming out. The baby is, this girl is going to experience pain in lower abdomen, but that will be cyclical, very important. Similarly, please, unfortunately, there is a diagnosis, and that is ectopic pregnancy or intrauterine pregnancy sometimes. I have seen these patients, unfortunately, sometimes. But keep in mind, if the girl has started the period and at a very young age, you look for any missing of the cycle, keep in mind when you have to look for the abdomen as well. Now, first of all, I'll start with the normal features of bowel in neonatal ultrasound. There are certain normal signs which you should look for. But I know if you don't know the normal, you will not be able to know the pathology. And the bowel wall thickness in newborn babies is 1.1 to 2.6 millimeters. Similarly, bowel echogenicity is very important. The normal signature. The normal signature means if you use 10 megahertz probe in a child of a few days or a few weeks, and you slightly compress it, you can appreciate this 4 layers. Similarly, we do the transrectal ultrasound, and in the rectum, we can appreciate all these 4 layers. And the first, which is a bright echo, you can appreciate it. That is interface from the mucosal surfaces. And second, which you find hypoechoic layer, is the deep mucosa and the muscularis. Again, which you see this third line is hyperechoic, which is bright echoes, that is submucosa. And finally, is the muscularis propria, which is again hypoechoic. And finally, the last one is the interface between the muscular propria and other ones. So please make sure if you find these 4 layers, 2 are hypoechoic and 3 are hyperechoic, that is the normal signature of the gut loops, because that is very important once you are looking for any gut pathologies in the early days of life. Similarly, vascularity, you should look for the normal vascularity, and bowel peristalsis. In normal babies, at least 10 contractions per minute should be observed in each quadrant. These are the normal, and then we look for the pathology. When we're thinking of the necrotizing enterocolitis, number one, the risk factors. Is there history of premature baby? Is there history of intestinal dysbiosis? Is the baby low in birth weight? Or if there's any cardiac pathology or patent ductus arteriosus, or if the mother has taken indomethacin or the baby. Now, what are the features to look for neonatal ultrasound in a suspected case of NSC? I hope you all know what is neonate. Once the infant, neonate is less than 1 month, and neonate is less than the infant is less than 1 year. If you find the bowel wall more than 3 millimeters or less than 1 millimeter, as it shows in the normal, 1.1 to 2.6, and here I'm saying, if it is more than 3 millimeter, that means there is edema, there is thickness wall. And if it is less than 1 millimeter, start thinking any risk of future perforation, chronic disease. Bowel wall echogenicity, loss of normal signatures. Those 4 layers, which I told you earlier, muscular mucosa and the submucosa, that is lost. Long segments of small bowel inflammation, thickened paravalvular conjunctives, herringbone or the zebra pattern. I'll show you the image right now, and they become hyperechogenic. So if you start looking for these things, you will find it. Bowel vascularity, increased vascularity. I'll show you how it becomes very vascular there. Abscess of bowel stenosis. I discussed with you 10 plus movements, but here you can find 3 to 4 movements in 1 minute in each segment. And there's a small amount of free fluid. This free fluid is only seen if you use a very high resolution ultrasound probe like 10 megahertz and the 7 megahertz. Not with routine 2 megahertz probe, you will not be able to see any of these features in a neonate. So please, the probe is very important. Nematosis intestinal, I'll show you that. Small air in the wall, and portal venous gas. And finally, pneumoperitoneum. So all these signs you should look for, which I share you now over here. Look at the first slide on your left. If you look at this gut loops, moderate wall thickening, don't find those classical signs of those 3-4 layers as I showed you here. If you look at this muscularis propria, is thick, is hypoechoic, and more than 3 millimeter total diameter. That hypoechoic means, compared with the mesenteric fat, loss of normal gut signature, which we discussed earlier. The 4 layers, don't appreciate any of the 4 layers. Look at downstairs, look at the wall. If advanced stage, the bowel wall may be as thin as 1 millimeter. So diffuse thinning of the bowel wall due to the progressive sloughing of the bowel wall layers into the lumen. So then thin out means long-standing disease. And free anorganic fluid, you can see in between the gut loops, small amount of free fluid, you can appreciate something. Another finding which I showed you, portal venous gas. Normally, these portal channels are black, hypoechoic, and you cut it up and reduce, you find the blood flow over there. And these channels are sometimes seen with this air. The diagnostic sign for air and pathology is that the gut loops and the air, they always change their site and size. While the actual pathology, if it is there, other than gas, that will not change it. So if you increase it, number one, they are dirty shadows. Number two, they are variable in size, and they are keep on moving over there. That is the diagnostic sign. Similarly, if you look at this downstairs here, you can find these gut loops, and they are persistent in the wall of the gut loops. If you keep the probe here, all these air shadows will be changing their size and site. But this echogenic shadow will not change its size, suggesting this air has gone into this wall, and that is now static, and that is not mobile because it's not in the free space like in the portal channel or like in the lumen. Similarly, use the linear probe. You can find a small amount of free fluid over there, and you can find pneumoperitoneum. You find bright echogenic line, very thin line. You won't find as you appreciate, but thin line along with this free fluid in the space, free space, you appreciate that, and the hyperechoic line suggesting of this pneumoperitoneum. Now, what is the vascularity? Normally appreciate symmetrical blood flow, small vessels, But here you can say the current Doppler and the power Doppler is better because power Doppler can pick up the small low velocity vessels, but current Doppler can pick up slightly higher velocity vessels. So if you introduce the power Doppler, you can appreciate rich blood flow, suggesting that vascularity has increased. Similarly, you can find the zebra sign, long segments of the small gaps loose, and then mucosal thickening. You can appreciate here it is thickening, and this area you can appreciate that is known as the zebra pattern sign. The next diagnosis is very important, hypertrophic pyloric stenosis. This is very important. There used to be X-rays and other modalities, and let me share with you, if you use this 7 megahertz probe, it's a very, very 100% diagnostic sign from the surgical and the management point of view. Do you need a surgical management or not? And that is seen between 4 to 6 weeks. And this projectile non-bilious vomiting, that's very, very important. Bilious if it is next to the entry of the common bile duct. That's why I say non-bilious. Early infancy, 6 months of age, but normally we appreciate 4 to 6 months. They're projectile vomiting all the time. Risk factor, it is a firstborn male. The ratio is 4 to 1. History in the first degree relatives, preterm birth, maternal smoking, and paternal erythromycin. They're relative findings, but more important thing is, can you appreciate? Yes. And please look for 3 classical signs of ultrasound, which cannot be missed at all with this ultrasound. Number 1, the thickening more than 3. As I told you earlier, the wall thickness is less than 2.6 and 1.1 millimeter more. If you find more than 3, means 4 millimeter, 5 millimeter, that is a classical sign. In transverse diameter, the wall thickness. This is the individual wall of the gut loop at the level of the antrum. I'll show you the image here. If you do a transverse section, that will typically give you a donut appearance. And the total diameter from AP diameter should be more than 11 millimeter. 3 millimeter each wall, say 4 millimeter each, and the air and the mucosa in between. So if it becomes total more than 11 millimeter, that's a classical sign. Third, the length of the antrum, which is causing this stenosis complete, that should be more than 15 millimeter. If you find these 3 classical signs, that is a sign of hypertrophic pyloric stenosis. But it's a very small catch point in that there should not be any movement of air in this segment. If you find any movement of the air in the segment, think of simple pyloric spasm, and that is medical management. That's not surgical management, because in stenosis there's complete obstruction. Other than that, the 2 signs, antral nipple sign, the pyloric mucosa, because of the pressure over there, is projecting back into the gastric antrum, which is distended and filled with the fluid. If you put the probe on the left hypochondrium from the side of the baby, you'll appreciate this lot of air and gas, air and the fluid in the stomach, which is filled up. Mass to feed here, and the fluid is coming in the stomach, but it's not projecting onward. On the contrary, the baby is vomiting. There is cervical sign. We call that inverted cervical sign. If you see a lady, or if you see a non-gravid uterus, you appreciate very nicely appreciate the cervix, the internal loss, the external loss, and in between you can find the cervical canal, which is about 3 to 4 centimeters. That is normal. Similarly, once you find a lady pregnant, who is a special case of incompetent internal loss and dilated cervical canal, we have to see the internal loss, external loss, and in between this length, that is the cervical canal. So please, that I just shared with you. Make sure if there is any signs of movements of the air in the gut loop in that segment, it's ruling out this pyloric stenosis. Now I'll show you the 2 images. That is the longitudinal image, and that is the transverse image. This transverse image is known as the donut sign. And normally the surgeons, pediatric surgeons say they can feel the olive sign on the right side of the midline in the epigastrium. So they can see this small nodule over there, but the diagnostic sign is ultrasound is very, very, it's close to that's the gallbladder you can appreciate. These are the gut loops you can appreciate, bright echogenic, they're not stones, it's outside the wall. And then you can appreciate this solid structure, black hypocare, which is the mucosa, as central is the echogenic, this wall, and the central is the echogenic mucosa. Whatever the air is lying over there, normally there's no air and there's no movement. And this AP diameter, and that's the longitudinal sign. You can see this at the level of the entrance of the antral canal, and there's the exit. And this is dilated segment of the stomach, which is a fluid field, and that's projecting. If you look at this, those of you who have the experience of seeing the cervix in gravid uterus, you can appreciate this normal internal loss like sign and this external loss sign, anterior wall of this antrum, and that is the posterior wall, and that is the mucosa, bright echo. But do not see any echogenic movement to it. So this bright is the mucosa, and the total diameter over here is 14 millimeter, and the individual wall is around 6 millimeters. You look at the bottom, this is number 5, this is 6 millimeter, and normally it's more than 3 millimeter. And if you look at the length of it, number 2, that's about 18 millimeters. So 6 into 14 into 18 millimeter is a classical sign of hypertrophic pulmonary, and there's no doubt. You may use other modalities like here I can show you here. This is a segment which is grossly dilated, and this is a narrow segment over there. You can appreciate it. But let me show you this 1-month-old baby who is to persist vomiting. But if you're using this 7 megahertz probe, a slight compression, there's no doubt that you can't diagnose it. Rather, you can never miss the diagnosis. Third diagnosis, interception. I say number 1, other than these 2 pathologies, if you find a baby of more than 6 weeks and there's history of pain or abdomen or pain abdomen, and the most common abdominal emergency which is seen in the childhood. Second most common cause of intestinal obstruction in the infant. 9 to 24 months more common than males, I told you earlier. Invagination of proximal loop or intestine intrusion. What happens? The proximal segment is going to the distal segment like this. So distal segment is holding this proximal segment, and that is known as interception. There are 3 types. There are ileo-ileal, which is mostly seen on the left half of the abdomen or the mid-abdomen, and the most common is the ileocolic, which is seen in the right iliac fossa, and the third is corocolic, which can be seen in the epigastrium or in the left hypochondrium, because the transverse colon is going into the distal colon, and if the ileo-ileal, it is in the mid-abdomen or maybe on the left side. The classical triad of interception is intermittent colicky abdominal pain. Mom will shake the shares that baby has got pain. There's vomiting, and diagnostic sign is current jelly. So please take the history. Does the baby pass current jelly tooth, which is diagnostic for your health? Other clinical signs are lethargy, abdominal mass. Now, the classical sign I told you, this is known as a donut sign or a target sign, single hypoechoic ring with hyperechoic center. This hyperechoic center, the most center is the mucosa, and that is the outer wall, which is known as interceptum, and intercipient, and that is the interceptum, which is going inside it. You can appreciate this outer, which is the distal segment, and the inner is the proximal segment, because the proximal segment is invaginating into the distal segment. So basically, you will appreciate 4 layers: anterior, outer, then the layer of the anterior of the receiving segment, then the posterior layer of the receiving segment, and finally, this last is the outer segment is again the receiving. So in the 2 layers are of the septum, which is projecting inside, and outer layers are of the receiving segment. Number 2 week, if you take a longitudinal section, this is known, I hope you are appreciating, this is a sandwich sign or pseudokidney sign. This is the outer wall of this segment, proximal segment, and that is the inner segment, which is the receiving the segment. The 5th month old, sorry. Again, you can find over here, you can see this proximal segment, and that is the distal segment over there, which is going inside it. And that large pseudokidney shape. You must appreciate. Very important one thing, sometimes babies, they have transit inception. Just you see that there, and after half an hour, you go to better machine, bigger machine, it may disappear. So this is known as intermittent or transient interception. That is going to be help the diagnosis, surgeon to manage the patient, because of normally the lymphadenitis over there, because the lymph nodes are there, they appear and sometimes they disappear. So if it is persistent and the history is there, that means it doesn't change it. So if you find somebody once it's there, then please sometimes repeat it and you can confirm it is persistent or not. And that is sometimes in adult patients, even babies, you got any doubt. But I think in ultrasound, there's no diagnostic doubt in that. But if you doubt, you can do this barium enema. You can say this barium enema. This is the segment which is of the distal segment. Next is intestinal malrotation and mid-gut volvulus. I hope I'm audible to the participant. Can you hear me on, please?
Yes, carry on, please.
Please, thank you very much. Intestinal malrotation can be either symptomatic or asymptomatic. Intestinal malrotation predisposes the mid-gut volvulus, surgical emergency, and presents with the bilious vomiting. Again, it's listed with that. Ultrasound finding very, very important. Malrotation abdominal, abnormal reverse rotation of the SMA and SMV. If you look at the normal relation, SMA is on the left side of the midline and SMV is on the right side of the midline. Color Doppler, parallel appearance of the mesenteric vessels, were loop signature sign. Evaluation third portion during them to confirm its location behind the SMA. And that's the classical signs on malrotation or the valvular gut loop. You can appreciate, if you put the video clip on or there, you can appreciate this volvulus and you can appreciate here and the central portion and the vessels have been altogether changed their direction, and that is the diagnostic sign. And somebody can appreciate this here. This is basically the vein, and here is the heart. It is a change of pattern, change of shape, and you find this alternating rings of high and low echogenicity with one loop vein sign. There you can appreciate that here. Acute appendicitis is very, very common, but if the baby is younger age, please keep in mind interception instead of appendicitis. You don't say appendicitis, no. Classical appendicitis will be repairing the right fossa, but please keep in mind very few percentage patients will have appendix on the left side, because in that case there is situs inversus. Instead of liver on the right side, the liver is on the left side. If you find the liver on the left side, all the gut will be rotated, so please keep in mind maybe less than 1%. You can appreciate the appendix on the left side. Graded compression, diagnostic sign aperistaltic. That is where the gut loops are always peristaltic. They are changing their size and height all the time. But in this case, you'll find the tubular structure, but this aperistaltic means it is not changing its size and size is persistent. And number two, normal gut loops are always compressible, and this segment is never compressible. The normal diameter of this appendix is variable because of the change in size, but if it persists and doesn't change at more than 6 millimeter diameter, start thinking of it. And surrounding minimal fluid, that is because of the inflammation or at times because of the early signs of perforation. Keep in mind. Adjacent mesenteric lymphadenopathy, very commonly, you appreciate these infections. Target appearance sign, I showed you a donor appearance sign, and normally sometimes you appreciate the appendiculis at the distal end, which is a closed end. You can find echogenic speck over there. And if you delay the diagnosis, the patient comes after some time, a couple of days or so, you can find the appendicular abscess, appendicular mass over there, a small amount of free fluid or good amount of fluid, depending on the signs and symptoms of the patient and how delayed the baby is coming to you. Important to visualize that entire appendix is provided false and active reading. Sometimes only distal tip of the appendix inflamed. Very appendicular fluid accumulation may indicate an early perforation, simply result from the inflammation. Classical signs I showed you here. You can appreciate this loose segment here. I'm compressing over here, but it's not changing. That is the flabellus at the distal end. And you can see the long segment. Similarly, you can appreciate here this long segment. You look at this, the long segment of it, which is containing debris, oblique specks, and distally you can find the echogenic flabellus. And there are 4 signs which preferably you look for. Number 1, non-compressible dilated segment of appendix. That's 1, if you find on that. But by the time we see that, we find 3, 4 things more. You find the omentum, which is becoming the bodyguard, that is echogenic surrounding this appendix. Number 2, very small amount of fluid, which is because of inflammation. And number 4 is the multiple small lymph nodes in the vicinity. And finally, you find the ileus, non-propulsive movements of the ileus. So the more you add the signs, the more you get the closer to the actual diagnosis. Let me share with you on ultrasound with a high resolution. If you say this is appendix, this is more than 95% appendix, maybe 90, 100% is appendix. But if I say there's no appendix, that doesn't exclude my diagnosis of those 20%. I can say 80% there's no appendix, but 20% patient may have appendicitis, which I may not be able to elicit that because of 2 things. It may not be in the same place, or this may be very early sign, or it may be retrocecal. So if the retrocecal appendix is there, you'll find the cecum in between your probe and the feet appendix, as you may. So the gold standard is then go for the CT scan. Here you can appreciate this here. You can see large distended, more than 20 millimeter distended segment of appendix, full of deposited fluid, echogenic specks, small amount of fluid surrounding, and there's a omentum. So all the 4 classical signs of acute appendix are appreciated over here. And look at this, sometimes if you delay or the patient comes late after some time, nature is always there to facilitate. There's a guard-like structure over there, and you can appreciate this thick deposited collection which is giving the appearance of appendicular abscess. Similarly, if you go down here, there's appendix and this abscess formation, and sometimes you find this mucosine, large distended segment, whirl loop appear like onion loops. You can find this segment over there. No doubt it's it's not very painful. The baby is not very colicky as the patient having acute appendicitis, but you find the grossly distended segment of the appendix with fluid filled, and you find these movements into it. That is diagnostic for the mucociliary appendix. There I say, if you find this intrathecal appendix, you can appreciate this ascending colon and there is cecum, and you can find this appendix right in same in the retrocecal area, so that you can sometimes miss because of this gut loop line between the probe and this appendix. So 100% diagnosis, if I say no, that doesn't confirm it. Number two, coming to the small children, orchitis. That's very, very important. The patient comes to you in emergency, and the differential diagnosis is it a case of normally it is referred by the pediatric surgeon, which is my experience, and they're sitting in the theater or in the clinic. Pediatrics, they think does it have torsion or not. So very important sign, is it a torsion or is it appendix, acute orchitis, because the management is entirely different for the both of the findings. In case of orchitis, you can appreciate this normal testis, and you can appreciate this blood flow, scanty blood flow you can appreciate over here. But in case of orchitis, you can increase the increased vascularity. Look at the blood flow here, and look at the blood flow here. When increased vascularity, rich blood flow, hot, tender testis baby, so that excludes the surgical emergency. That means it is the orchitis. Sometimes there is still pain, swelling, and tenderness over there, but the testis may be absolutely normal, but you find this large, distended, thick deafness fluid in the scrotal wall, and that is scrotal abscess. You can appreciate that. Testicular torsion, that is another emergency. But here my take-home message is, please, if you find anywhere, the time of the baby is very, very important. If the baby comes to you in the 4 to 6 hours, that's the first thing. If the baby comes late, that is first. That is the first slide that shows this slightly overlap. The first thing is initial 4 to 6 hours. It may be absolutely normal texture or normal glow up to maybe 4 hours. Hyperemia may result in its early stages due to venous dilatation at the periphery. Spectral waveform is very, very important. That is the catch point in this entire slide of torsion. The normal is, that's a beautiful slide. You can appreciate the normal testis, the normal blood flow, normal, and there's a normal blood flow. It is low resistance, high diastolic flow. That is in the normal testis. Even if it is inflammation, the pattern will remain the same. But if you find a baby with the early hours of suspected torsion, you do this CARDA. But there are two signs that are going to happen. Number one, the testis, instead of remaining longitudinal along the body, it becomes transverse like this. You can appreciate here, and the other testis normal is here. And the diagnostic sign is introduce the color Doppler. No doubt you'll find the blood flow, but there's absence of diastolic flow. That is a sign of intermittent torsion with horizontal testicular position, suggestive of hyperemia, and that is reversible. So that is the take-home message. Similarly, increased vascularity, horizontal textural position, and episodes of pain. Baby will have attack of pain, then maybe attack, and that is in the first 4 to 6 hours, and this can sometimes it is more than 6 hours. But if you find after 24 hours, there's a heterogeneous texture. The picture is altogether changed. So if you find a baby complaining of pain in the testes, please take the history and immediately get the ultrasound, because that is the diagnostic very helpful from the symptom. But if you delay for 24 hours, koi baat nahi, goli khane khairiyat hai. Please feel the tenderness, feel the hot area, and physically examine and see the testis lying position. If the testes are lying vertically, that is normal position. If you find any testes on your touch, it is tender and is lying slightly horizontal, start suspecting it is a case of intermittent torsion. But if you come after 24 hours, there is slight heterogeneous texture due to congestion, ischemia, and non-homogeneous texture. There you appreciate that. In the other testes, you appreciate the blood flow, which is normal, and other testes, second testes, this gross nerve. This doesn't become any more oval shape. It becomes globular. It becomes enlarged, maybe 20%, 30% size increase. And the peripheral rim is hypocave, where you can find sometimes flow that is not flow of the testes, that is flow in the wall tunica, and there can be flow in the scrotal wall. If you look at the scrotal wall, it's thin. If you look at the scrotal wall, it's thick. So scrotal wall is thick. There is mini hyperemia over there, and in the center of it, after 24 hours, hypocave. It can be even showing some degenerative changes. It may show some complex picture. I show you in the next image. So please make sure there is no blood flow. The size is large. It is globular. It is no more oval shape, and the scrotal wall is thickened, edematous, with minimal flow at the periphery. That is not a case of torsion of the blood flow. Role of Doppler: decrease absent blood flow in affected testicle, as I told you in the early phase. Power Doppler should be used because the vessels are very low velocity vessels. Testes में average velocity flow होती है, वो 8 to 10 centimeter होती है. So normally if you use this color Doppler or advanced, that may not be able to pick up the small vessels. So go down to the power Doppler where you can pick up these small velocity vessels. Again, preserved respiratory Doppler doesn't include vessel torsion. That means that is in intermittent phase. It come attack and then relax settles. So that is phase for going to that. Twisted spermatic cord, one loop sign, sensitivity and specificity. Location of twisted spermatic cord varies from just distal to the external monitoring to or above or posterior to the testis. Then you can appreciate the torsion. You can down the testis, blood flow, and you can appreciate minimal blood flow at the periphery. Again, you can appreciate it. And you can look at this epidermis torsion. The testis is normal. Here the testis are torsion. Sometimes both are twisted or maybe one epidermis. If you look at the epidermis, it is double the size of the opposite normal. Always compare one test with the other. The nature is very kind to age this pathology as compared with the opposite side, which it is involving. And this becomes large, hyperechoic. Again, there is absence of blood flow. Again, you can look at this epidermis, large, heterogeneous, and there is no blood flow. Torsion of the variant cyst. Normally, it's rarely seen in young girls, but just 3 days back, I saw this young girl. I show you, there was 14-year young girl. The venous fluid, peripheral cysts. These cysts are not cysts. Basically, these are the venules. Because of the congestion over there, the veins get congested, and you can find low resistance vessel over there because of the venules. You must appreciate the pedicle. Just rasta nahi hota, like that, you can appreciate it surrounding the cyst. And you can find small myocytes. These cysts are basically hemorrhagic cysts. That's why I say if you find a young girl of cyst more than 6 centimeters, wait for 3 months, 4 months. If it disappears, fine. Otherwise, you can simply do the aspiration to avoid this torsion today. What are the signs? Enlarged edematous ovary with peripheral displaced follicles. Presence of twisted vascular pedicle. Rare but highly specific signs. I'll show you here. Absence of flow infarction. Presence of flow viable ovary. So very important signs I'm looking for. Look at this young girl. Very recently, this young girl of 14 years came about in this month of May. And you can appreciate this normal uterus. Their uterus is barely the size of uterus in this young age, 13, 14 years. This is 14 years. Age, female, 1 day stiff, lower abdominal pain, very acute pain. Now the differential was basically she came with suspected appendix. But the appendix was normal. Now there's a large cyst, hemorrhagic cyst, and this large hemorrhagic cyst. And then you appreciate this echogenic area over there. That echogenic area is basically the pedicle, which is twisted around it, and you can appreciate the small amount of ascites. So ascites, hemorrhagic cyst with the debris, and you can find small amount of fluid, and this solid component. Look at this ovary is finishing here, and that is solid component. Is ऊपर जाके इसने उसने twist कर लिया हुआ है. That is twisting of. And then I show you video. Look at this uterus. That's the uterus coming here. The absolute normal uterus cervix, but you can see a small amount of fluid. There's a pedicle twisting over there, and the central hemorrhagic cyst with surrounding echogenic area. So that is diagnostic sign of torsion. She was operated immediately, and then it was a confirmed finding that is torsion of variant cyst. Similarly, you see very small babies, sometimes 3 to 4 years. Mama कहती है जब मैं बच्ची को नहलाती हूँ, very important sign please. When she takes bath, बच्ची को नहलाती है तो जब हाथ उसका नीचे देखता है तो just close to the symphysis pubis on the right side, on the left side she finds a swelling, and the diagnostic sign is it a hernia or it is anything else. तो जब वो बच्ची खड़ी होती है नहाती है तो हाथ ऊपर जाता है मामा का, तो वहां पर उसको सरी नजर आती है. Mostly, commonly, it is a case of hernia, or you can see this rarely hernia of the ovary. Normally, the gut looks herniating down, but rarely you can see the ovary. Look at this image over there. There is symphysis pubis, and there's bladder coming slide down. Look at this ovary of this young girl, 4 years, is coming down into this inguinal canal. So that is canal of neck, where you can look, where you can appreciate this ovary heading down. This young girl of 14 years, 4 years. Hematocol pulse. As I told you, please listen to the history of the patient. If the girl is 11, 12 years old and she complains of cyclical pain, हर महीने मामा मुझे थोड़ी सी pubic में दर्द होती है. Don't just ignore it. Don't treat every girl complaining of hysteria or functional or other things. Please just simple one ultrasound and listen to the complaint of the baby. Look at this girl. She was complaining of pain in her abdomen, but she didn't have periods. So mama says she might get periods in a couple of months or so. That's why the girl started experiencing pain. Get one ultrasound, which takes 1 second, and by the time it becomes more and more fluid, the pain gets worse. Initially, maybe small amount of pain because minimal fluid of this mesocycle. As he gets a couple of months down the line, the amount of fluid. Look at this baby over here, large hematocol pus, and over time, this external os is open, the internal os is open, and the fluid is down into this even a uterine cavity. You can see small hypokaria over there. So this is hematocol pus, and even this you can see salpinx. Look at this fluid going into the fallopian tube on this side. The ovaries are just preserved. So bilateral hydrosalpinx, hematometra, and hematocol pus. That means she must be having complaints for more than 1 year, which has been ignored and not diagnosed. Unfortunately, I told you, please always take care of the ectopic pregnancy sometimes. The girls, they were starting having periods and pain abdomen. Sometimes the girls do not know it, unfortunately. Even I've seen the girls intrauterine pregnancy and even the extrauterine pregnancy. That is, you can appreciate this. You can see the uterus normal. You can appreciate this gestational sac with the fitted pole, with cardiac activity, and you can see the ectopic pregnancy. Let me share you one positive item here. We are managing the ectopic pregnancy by injection methotrexate within it. So instead of going to surgery, which creates a lot of physical trauma, and the young girl, sometimes that is a bad name. So you can manage the ectopic pregnancy by simple medical management, putting it half cc or less than that methotrexate. This is terminated on the spot, and the patient gets fine, and they can go home. So history again very important. If the girl or the boy, young boy, is complaining of colicky pain and colics, severe pain, history very important. If the pain is up in the right left lumbar area and goes down to the pubic area and down to the side, medial thigh, think of this stone. And if you don't find any stone in the kidneys, my take-home message, please immediately go down to the bladder, fill the bladder, and see the uretrovesical junction calculus. If you don't find the stone in the kidney, go down immediately. If you don't find the stone there, if you find the dilated pelvic system, see the ureter, फिर आप gradually उसको trace करते नीचे. Otherwise, if you put a probe at the kidney, you see the hydronephrosis, you don't see the stone, go down to the bladder, and 80% stones are lost there. If none of the two places is showing the stone, but hydronephrosis, then gradually you taper this, trace this ureter down the line. Metabolic diseases, congenital, all the hypohydronephrosis. You can appreciate this patient over there. The calyces are dilated, the pelvis is dilated, and we're trying to trace the ureter, and there's a small echogenic stone over there in the mid-ureter. And then you appreciate the stone, there's dilated pelvis and calyces, but the stone is the uterovesical junction. Important thing is, look at the length of the stone, look at the thickness of the stone. These two things are very important because that's going to convey the message to the management. If it's a small stone, less than 5 millimeter, 6 millimeter, and 2 millimeter wide, ये खुद ब खुद निकल जाएगा, दवाई से भी निकल जाएगा, सर्जन से भी निकल जाएगा, हकीम से भी निकल जाएगा, अम्मा से भी निकल जाएगा, because it's going to pass it on. The only message is follow it up by ultrasound, has it passed on. The moment the patient feels relief in the pain, that means it's passed it out. But at times, you don't see the stone, but the patient signs are there. The gold standard today is not ultrasound because the gut loops over this entire abdomen. The gut is also bright, because the stone is also bright, and sometimes stone is, as the ureter is lying along the posterior wall over the psoas muscle, you may not be able to reach the area of your target, and you can miss it. So best is do the CT scan. That is diagnostic sign for that. Please, this is again very important. If the baby is complaining of pain, right hypochondrium, don't just ignore the complaints. Look into the eyes. If the baby has got, or the girl, the boy has got this shallow discoloration of it, everything is not surgical. Think of something else. And let me share with you, if you find the ultrasound, the classical finding, you can find the gallbladder wall thickened edematous. The normal wall of the gallbladder is less than 3 millimeters. Here you find more than 10 millimeters. Please, one take message for all my colleagues is, this is not cholecystitis. This is not cholecystitis. I remember 2009 and 10 when this dengue fever started. One of the signs was gallbladder wall edema, and many operations unfortunately were operated because of acute cholecystitis. Please, the A calculus cholecystitis is less than 7%. So if you find this gallbladder wall thicker and this portal channel is prominent, which is called the starry sky liver, this is not a case of A calculositis. Look at the serum bilirubin, that will be raised. Look at the all the details of LFT. But obstruction will not be there, but ALT will be raised, serum bilirubin will be raised. Treat the cause with simple medical management and not a surgical management at all. Why I'm stressing on this patient? Because many times the patient operated because of A calculositis. So my younger colleagues who are doing the ultrasound in the initial days, please, once you find gallbladder, तो आप लाइट जला के जरा उसकी आंखों को भी देख लें, उसके बेटा आंखों पर सर आंखों पर करें, look at his clear eyes, or does he have white color yellow color stool, does he have nausea, does he have tenderness, does he feel like taking the food? All these signs are suggestive of acute hepatitis. उसका liver भी enlarge होगा, उसको tenderness भी होगी, उसको vomiting भी होगी, उसको urine discoloration होगी, उसकी eyes भी करो. So these 3-4 small petty questions can give you a 50% clue to your diagnosis. This is a case of acute. This is not the inflammation of gallbladder. That is because of close contact of the wall of the gallbladder with the liver. When the liver becomes edematous, liver cells become more hypoxic because fluid. The wall is becoming edematous because of the fluid over there. So this is gallbladder wall edema because of the hepatitis and not because of its own acute cholecystitis. I'm just finishing a few more slides. Pediatric emergency trauma, please, history of the baby is very, very important. Does he or she have any trauma? Very strange case. This young boy of 6 years, very long time back in about 25 years back, I did this patient. Very strange, this baby was brought to me with a history of suspected typhoid ulcers. Very strange. He had fever, he had pain in abdomen, and the baby was referred to me. When I did the ultrasound, look at this ultrasound. Look at multiple hypochondriac, vaguely outlined, not discrete. Look at this here, and look at this here, look at this here, look at this here. There are multiple variable size, small, hypochondriac, irregular areas which were divided of Doppler blood flow, except sometimes cannot be shaped. And a small amount of ascites. Somebody did the ultrasound. They said small ascites, temperature, bukhar, and suspicion of typhoid fever. When it please talk to the patient. I always say my younger colleagues, ultrasound is the only modality which is the most clinical modality. You talk to the patient, right? The history. जो काम आपके पीजी लेना है, जो हॉस्पिटल मेडिकल you become the clinical to the patient. When I talked to the baby, the history was very, very strange. He signed the stool, so lunch break हुई इधर ये बैठा था, दूसरा बच्चा बैठा था. So when he slipped, उससे आप घर ले जाओ. That happens in all the schools. They took him to the hospital. He had reactionary fever, which he had to, and he had severe pain. They said typhoid हो गया, बुखार हो गया. So baby was admitted in the hospital, then referred for the ultrasound. The initial ultrasound showed only fluid in the pelvis, which confirmed is a case of typhoid ulcer, and he might be bleeding, leaving this leaking the typhoid ulcer. But when I talked to the baby, it was hematoma formation, grade 1, and a small amount of ascites. It was not ascites. I put a needle over there and I spit the blood, which are basically hemoperitoneum. The question was, as it was grade 1, so he doesn't need any surgical management. Simple needs management after some time observed, the baby was absolutely okay. Please history the baby is well. That's what I will show you here. This is another patient. Bilal, 9 years. Again, history of psychosis गिर गया था बच्चा. Look at hematoma formation here. Look at hematoma segment 6 over there. Similarly, another child, he is a 3-year child, जो बच्चा गिर गया तो उसको अब दर्द हो रही है लेफ्ट एप्रोकॉन्डियम में. Again, you can find this perinephric area. There is a fat and there's slightly fluid over there in the lower pole. You don't find this very discrete, very smart. As you can hear, there's slightly heterogeneous, slightly hyperperia and a small amount of fluid over there. That is a grade 1 in a trauma. Again, this does not need surgical emergency. It is a medical emergency. Just follow them, observe them. After weeks, the ultrasound, and you can become normal. Unless this is grade 4 trauma, which are diagnosed by ultrasound and follow with that and the management starts. So renal trauma grade 1, simple medical management. Pancreas, again, history of trauma. Let me share with you the normal pancreas for those of my youngsters doing the ultrasound. The texture of the pancreas is always more than the liver. Yeah? Reference होना चाहिए कि मैं कैसे compare the normal and abnormal. If you look at the echogenicity, it is more than the adjacent liver and spleen. Spleen and liver, they are almost at the same texture. If you find it more echogenic, that's normal. Splenic pancreatic pathologies, they are always 99% they are hypokic, whether it is a tumor or whether it is a hematoma or whether it is a trauma. Look at this normal and look at this texture. And this texture shows there's a hypokic area and a small amount of fluid over there, and the age of the child is protocyanic. What happened? 2 days history of cycle trauma. Cycle जा रहा था तो वहाँ गिरा, तो उसके बाद उसको handle cycle का epigastrium में जाकर लगा. And now the patient is admitted. Look at the urinary bladder over there, and look at the small amount of ascites, which is basically peritoneum, and the pancreas over there is slightly heterogeneous. Small amount of fluid in the peripancreatic area, and heterogeneous texture and small fluid. It's again pancreatic trauma, which needs medical management. Sometimes you find the testes. There is history of trauma on the left side, and you find this atrophic testes. Similarly, you can find this history of trauma, and you can find large hematoma formation from testes, and you can find this hydrocele on the other side. So my take-home message is, as I discussed, it's radiation-free, it's a bedside facility, it's a fast, it's a quick examination, dynamic assessment, and you don't need sedation because the smaller the baby, mother can simply feed at the same time, over sheet dalne, and we can do the ultrasound, and we can give the answer to a great extent, and there's no contrast allergy, and baby handling is not very difficult, and it's a real time, dynamic, steady. So my take-home message is ultrasound is used as the first line screening as well as the diagnostic tool. Thank you very much for bearing me, the members, for about.
Thank you, Professor Safdar Malik sir. Very nice and elaborative. मेरा ख्याल है कि कोई ऐसा लियन नहीं है pediatrics का कि जो आपने छोड़ा है. I am looking at almost more than a century people are here, and half century people are here, and inshallah we'll upload this video for the students and for the radiologists and the pediatricians. I think on behalf of आज इसमें ना कई सोसाइटियों के प्रेसिडेंट्स भी मौजूद हैं. रेडियोलॉजी सोसाइटी के प्रेसिडेंट भी मौजूद हैं. मैं इससे पेशतर के इकबाल साहब से, डोगर साहब से कुछ कहूँ. अपना एक फिजियोलॉजी के प्रेसिडेंट भी मौजूद हैं और पैथोलॉजी का प्रेसिडेंट तो आपके खाते में. प्रोफेसर खुर्शीद साहब, प्रेसिडेंट ऑफ पाकिस्तान सोसाइटी ऑफ रेडियोलॉजी, आपने जी. नवाज अंजम साहब, प्रोफेसर नवाज अंजम साहब, आई थिंक अनम्यूट, आप अनम्यूट करें ना सर. डोगर साहब, ओवर टू यू फॉर द योर कमेंट्स फॉर फर्दर. सर इसको जरा अनम्यूट, इसको जरा
अस्सलाम वालेकुम
जी, अनशेयर करें. जी प्रोफेसर Paul Hussain Dogar, Principal, Gujranwala Medical College and Chief Guest of today's session.
Sir, it is an excellent talk by Professor Safdar Malik, as he already given this talk in Gujranwala Medical College and covering all the aspects of abdominal emergencies. Especially, we should consider the age of the patient, whether the patient is a neonate, pediatric or infant patient. And one thing which he elaborated very well, that we should, after diagnosis, we should try that whether the patient needs medical management or surgical management. Sometimes we do some mistakes. There is a medical emergency and we open that patient. That is usually not correct. For example, if a patient with ascites come in the ER and it's tuberculous abdomen, so we should not open it. In my experience, have that some doctors do not correlate these findings and make some mistakes. So it's a really, really very wonderful talk. And Professor Safdar Malik is a really legend of radiology. And I hope that our future collaboration with you and these legends of radiology like Professor Safdar Malik, Professor Nawaz Anjum, Professor Khwaja Khurshid will be maintained in future in Gujranwala Medical College also. Thank you very much.
प्रोफेसर इकबाल
अस्सलाम वालेकुम जी, अस्सलाम वालेकुम
प्रोफेसर इकबाल डोगर साहब,
जी।
आपका टॉपिक कुछ इस तरह का था। इंशाल्लाह हम आपसे भी गुजारिश करेंगे, बड़ा इंटरेस्टिंग टॉपिक था पीडियाट्रिक ट्यूमर के ऊपर। मैं प्रोफेसर ख्वाजा खुर्शीद साहब के जाने के बाद फिर इजाज़त देता हूँ।
जी, अस्सलाम वालेकुम
जी प्रोफेसर ख्वाजा खुर्शीद साहब।
थैंक यू वेरी मच मुलाजिम बुखारी साहब, और थैंक यू वेरी मच टू द सोसाइटी ऑफ पैथोलॉजी जिन्होंने हमें ये फोरम दिया है। अभी इकबाल डोगर साहब फरमा रहे थे कि ये वही लेक्चर है जो सफदर साहब ने वहां दिया था, लेकिन मैं समझता हूँ कि ये ऐसा लेक्चर है जो कि हर महीने होना चाहिए। ये तो इतनी अच्छी रेपुटेशन है। और सफदर मलिक साहब हमारे इतने बेहतरीन उस्ताद हैं और इतने लेजेंड हैं हमारे रेडियोलॉजिकल सोसाइटी ऑफ पाकिस्तान में कि इनकी खिदमात बहुत ज्यादा हैं और इनसे टाइम लेना ही बड़ी बात है। तो मैं इसलिए बड़ा मशकूर हूँ आपका मुलाजिम साहब, और इंशाल्लाह अब ये सिलसिला जारी रहना चाहिए। और सफदर मलिक साहब की जो तदरीस का सिलसिला है ये भी कंटिन्यू रहना चाहिए। एंड आई एम श्योर जितने भी हमारे पार्टिसिपेंट्स हैं उनके लिए ये आज का जो ये टॉक थी has been beneficial and productive to all of us for our routine practice, क्योंकि ये वो सारी वो चीजें हैं जो रूटीन में हम प्रैक्टिस में देखते हैं। थैंक यू वेरी मच डॉक्टर सफदर, आई रियली अप्रिशिएट। आप सबका बहुत शुक्रिया और पार्टिसिपेंट्स का भी बहुत शुक्रिया कि छुट्टी वाले दिन उन्होंने ये टाइम निकाला। थैंक यू वेरी मच।
थैंक यू
बहुत शुक्रिया आपकी एप्रिसिएशन का। These words are important for me.
आपको पता है कि हमने ये जो सिलसिला शुरू किया था ये कम से कम बहुत पुराना है। हमने 2020 से प्रोफेसर सलमा कुंदी के साथ मिलके पीएमए के प्लेटफॉर्म पे हमने कोविड की इंट्रोडक्शन और कोविड के बारे में बताना शुरू किया और फिर इसके बाद हमारा सिलसिला एजुकेशन की तरफ निकल पड़ा। तो इंशाल्लाह दिस प्लेटफॉर्म इज़ ऑलवेज अवेलेबल फॉर एजुकेशनल एक्टिविटी। नाउ हमारे फिजियोलॉजिकल सोसाइटी के प्रेसिडेंट हैं प्रोफेसर राशिद मलिक साहब और एक अच्छे खुद बेहतरीन प्रैक्टिशनर भी हैं। राशिद साहब, आप सवाल पूछना चाहते हैं? प्रोफेसर राशिद साहब।
पहले तो मैं सर अप्रिशिएट करता हूँ इस सिलसिले को। 130 से ज़्यादा हो गए हैं और आपने भी पॉइंट आउट किया हमारे बहुत कम ऐसे वेबिनार होते हैं जिसको लाइव 50 से ज़्यादा लोग देखते हैं और ये उनमें से एक वेबिनार था। वरना ऑनलाइन बाद में रिकॉर्डिंग देखते हैं बहुत सारे लोग। और क्वेश्चन मेरे हैं कि सफदर साहब आज कुछ नेट के इशू था, मैं डिस्कनेक्ट होता रहा, अगर बताया तो दोबारा बता दें कि इसकी लिमिटेशंस क्या हैं, कौन सी कंडीशंस हैं जिसमें अल्ट्रासाउंड डायग्नोज नहीं कर पाता और हमें सीटी स्कैन या एमआरआई की तरफ जाना पड़ता है।
ठीक है, अच्छा सवाल है, अच्छा सवाल साहब, कॉमन सा सवाल है जी। जी अपना सफदर मलिक साहब, आपकी आवाज आप इसको अनम्यूट करें ना ताकि आपकी तस्वीर नजर आए सवाल जवाब देते हुए। जी जी, अच्छा इसको अनशेयर करें सर, अनशेयर करें इसको स्क्रीन को।
अनशेयर करें। आप आवाज आ रही है मेरी अब आपको?
सर इसको आप प्रेजेंटेशन को शेयर करें।
आ रही है,
आप ठीक है? गुड गुड
जी, आप ठीक आवाज आ रही है?
जी आ रही है बिल्कुल।
अच्छा राशिद, थैंक यू वेरी मच। मैं समझता हूँ कि अगर आपके पास अल्ट्रासाउंड मशीन प्रोब अच्छी है और ऑपरेटर भी ठीक हैं, अल्हम्दुलिल्लाह विद एक्सपीरियंस हैं, जैसे लेक्चर में इस लेक्चर के बाद बहुत सारे बच्चे इसमें लर्निंग कर लेंगे, तो ये जो मैंने आपको पैथोलॉजी डिस्कस की है ये ओवर द एक्सपीरियंस यू कैन डू एंड यू कैन डायग्नोज देम। बट अगर यहाँ पे किसी डिफिकल्टी आ जाती है, जैसे कि मैंने एक्यूट अपेंडिक्स में गुजारिश की थी कि आपको रिट्रोसिकल अपेंडिक्स है तो वहाँ आपकी लिमिटेशन आ जाती है, आप नहीं डायग्नोज कर सकते। दे यू कैन हैव द अपीयरेंस यूज ऑफ प्लेन सिटी एब्डोमेन। बल्कि प्लेन सिटी एब्डोमेन का ये एडवांटेज है कि रास्ता इसके साथ साथ आप स्टोन भी देख सकते हैं कि स्टोन एनीवेयर और अपेंडिक्स एनीवेयर कैन बी डायग्नोज, दैट इज द एरिया वेयर यू कैन डू। सिमिलरली अगर आपको इसमें डाउट हो रहा है हाइपरट्रोफिक पाइलोरिक स्टेनोसिस में, तो यू कैन डू द बेरियम swallow exam, बेरियम मील एग्जामिनेशन। उसमें इफ द कंट्रास्ट गोज थ्रू द एंट्रम सो दैट एक्सक्लूड द पॉसिबिलिटी ऑफ हाइपरट्रोफिक पाइलोरिक स्टेनोसिस। लेकिन अगर अच्छी अल्ट्रासाउंड है so you cannot miss the diagnosis of hypertrophic pyloric stenosis. You cannot miss it. So I think it needs a bit experience of the operator, and then he or she can diagnose most of it. Lekin jahan difficulty pade, you can always take the complementary other modalities, like I discussed this CT or barium, depending on the need of the pathology.
Any other question? Anybody ask the question? उस पे तो बहुत सारी लिस्ट थी, लेकिन एक चैट पे गुजर गई। और काइंडली सेंड दीज स्लाइड्स टू ऑल पार्टिसिपेंट्स। हम स्लाइड तो नहीं भेजेंगे, लेकिन हम इसको वो करेंगे, आपका वीडियो शेयर करेंगे इंशाल्लाह। अच्छा, इसके अलावा प्रोफेसर तनवीर जुबैरी साहब भी मौजूद हैं, बड़े सीनियर टीचर हैं। जी जुबैरी साहब।
जी अस्सलाम वालेकुम टू एवरीवन। डॉक्टर सफदर मलिक साहब और मेरा बहुत पुराना तल्लुक है। हम दोनों रेडियोलॉजी की ट्रेनिंग 84 में हम लोगों ने इकट्ठी शुरू की, और वहाँ हम लोगों की दोस्ती इस वजह से हुई कि हम दोनों बाकी जो बहुत एंथुजियास्ट होते हैं उनके मुकाबले में निस्बतन बैक बेंचर थे, और आपको पता है बैक बेंचर की दोस्ती बड़ी पक्की होती है। तो डॉक्टर सफदर साहब से मेरी पिछले उसी 40-45 साल से एक दोस्ती का मोहब्बत का तल्लुक है, जो हमेशा मजबूत ही हुआ है और ज्यादा ही हुआ है। और वी आर वेरी क्लोज फ्रेंड, कोलीग्स, हमने बहुत सारे इंस्टीट्यूशन में काम भी किया है। और सफदर साहब का जो ये पैशन है टू लाइक लर्न एंड टू लेट अदर्स लर्न और टीच, ये बहुत जबरदस्त एक चीज है। तो अल्लाह ताला इनको हिम्मत दिए रखे, और इन्होंने बड़ी अच्छा एक प्रेजेंटेशन दी। तो मैं समझता हूँ कि बड़ी आसान जुबान में उन्होंने सब लोगों को कुछ समझाया। तो थैंक यू
हम आपके
डॉक्टर
ग्रुप में
साहब।
भी इसको, इस वीडियो को शेयर करेंगे इंशाल्लाह। आपको एक रेडियोलॉजी बुक का एक नाम से बहुत बड़ा एक आप वो चलाते हैं। जी तारिक मलिक साहब फ्राम इस्लामाबाद। तारिक मलिक साहब फ्राम इस्लामाबाद।
अस्सलाम वालेकुम। माशाल्लाह, मैंने एट ए निक ऑफ इट मैंने ये वेबिनार कैच किया और अपने ग्रुप में शेयर किया, और बहुत सारे जो दोस्त हैं वो भी ऑनलाइन आ गए,
और वेरी
तो
सीनियर टीचर या माशाल्लाह आप भी।
और
जी
काफी इंफॉर्मेटिव था। और ये वेबिनार गायब गाए होने चाहिए। और आपसे रिक्वेस्ट ये होगी कि जो हमारा ग्रुप है उसमें इसका रिकॉर्डिंग शेयर कर दें।
जी, हम इंशाल्लाह आपके रिकाब काफी 800 बंदा है आपके ग्रुप का, बहुत बड़ा ग्रुप है आपका
बहुत
इंशाल्लाह
शुक्रिया।
उसका। अच्छा, इसके अंदर एनीबॉडी एल्स अगर आप क्वेश्चन हैं तो आप बाद में भी हमें भेज सकते हैं। हैं मेरे पास 2-4 मिनट, कोई सवाल पूछना चाहता है। दूसरी बात है कि अपने ईमेल भेज दें, हम इंशाल्लाह आपको CME सर्टिफिकेट्स ईमेल कर देंगे। हमारा ग्रुप उस पर हम वर्क, और हमारा ये जो वेबिनार का सिलसिला पिछले कई सालों से चल रहा है, उसमें हमने ये सिलसिला शुरू किया कि हम आपको आप सर्टिफिकेट भी देना शुरू करेंगे इंशाल्लाह बिफोर
जी
कंक्लूडिंग।
प्रोफेसर मुलाजिम बुखारी साहब, कैन आई हैव अ कमेंट?
जी जरूर जरूर जरूर, आप तो चीफ गेस्ट हैं आज की।
अच्छा, अभी आपके प्रोफेसर फिजाली साहब ने बड़ा अच्छा क्वेश्चन किया था, सीटी कब हमने जो है ना वो करवाना था। सर ने बड़ा अच्छा जो है ना उसमें किया था। उसमें एक सिर्फ मेरा कमेंट है कि जो ट्रामा होता है उसमें जो है ना वो, जैसे सर ने भी बताया कि देयर इज लिमिटेशन ऑफ अल्ट्रासाउंड, तो उसमें फिर गोल्ड स्टैंडर्ड जो है ना वो यूजुअली सिटी को हम जो है ना वो लेते हैं फर्दर उसकी स्टेजिंग करने के लिए कि लिवर की लैसरेशन कितनी है, या किडनी की लैसरेशन, या स्प्लेनिक लैसरेशन जो है ना कितनी। बट इनिशियल इन्वेस्टिगेशन is, as already Professor Safdar Malik said, that is the ultrasound grayscale and Doppler ultrasound. Thank you very much.
जी अपना हमारे PMA के सीनियर साथी बैठे हैं, सर आप साजिद साहब इस बोलना चाहेंगे कुछ? ENT के हमारे कंसल्टेंट है।
जी मुलाजिम साहब, मेरी आवाज आ रही है? अस्सलाम वालेकुम।
कैसा सज्जाद जी? जी मैं आपको इनवाइट कर रहा था।
मुलाजिम साहब बहुत शुक्रिया। मैं डॉक्टर कैसर सज्जाद हूँ, मैं ENT सर्जरी करता हूँ। मैं एक्सीलेंट प्रेजेंटेशन पे सफदर साहब को मैं अप्रिशिएट करता हूँ।
पूरी एजुकेशनल आज हमारा लेक्चर था।
बड़ी हमारी तालीम बालगान हो गई है हमारी आज। काफी कुछ मालूमात हो गया हमें, और कुछ चीजें हमने जो MBBS में पढ़ा था वो भी पता चल गया। मैं 81 का ग्रेजुएट हूँ, और वो भी हमारी रिवीजन हो गई। कुछ चीजें हम जो यहाँ जिन्ना हॉस्पिटल में कराची में जो पोस्टिंग होती थी, तो वो भी थोड़ा हमें याद आ गया कि हाँ, हमने बच्चों के वार्ड में ये सारी चीजें देखी थी। Anyhow, I think most of the participants have must be learned so many things, और उनकी रिवीजन भी हुई होगी, और कुछ लोगों ने ये इसको पहली दफा सीखा होगा। बहुत अच्छा। दूसरी बात है, तारिक साहब ने कहा कि ये इस तरह का वेबिनार होना चाहिए गाहे बगाहे। तो तारिक साहब, ये तो पाकिस्तान मेडिकल एसोसिएशन ने इसको जब शुरू किया, तो ये हमारी जो प्रेसिडेंट थी उस वक्त PMA की, डॉक्टर सलमा कुंडी, और मुलाजिम साहब ने मिलकर ये सारा कुछ किया शुरू। उस दिन से हर हफ्ते, बस आप इतवार को 11 बजे टाइम निकाल लिया करें, तारिक साहब ये वेबिनार खोलेंगे, आप कोई कुछ ना कुछ टॉपिक पे इंशाल्लाह बात होती रहती है, जिसके लिए मैं मुलाजिम साहब को और हमारी बहन डॉक्टर सलमा कुंडी को मुबारकबाद पेश करता हूँ। इनको अप्रिशिएट करता हूँ कि इनकी सारी कोशिशों एंड ऑल द एफर्ट्स के बगैर ये पॉसिबल नहीं हो सकता। तो एनीबडी, आई एम थैंकफुल टू ऑल द पार्टिसिपेंट्स एंड स्पेशली द स्पीकर डॉक्टर सफदर अली मलिक साहब, कि आपने आज बहुत अच्छा, आज मलिक साहब आज आपने मेला लूट लिया। थैंक यू वेरी मच।
अच्छा, ऐसा था कि अगली अपना कैसा सजाद अगला है जुम्मा ईद है, तो हम इंशाल्लाह अगले संडे ईद है, तो हम कोशिश करेंगे वक्फा दें, कुर्बानी करें। और इंशाल्लाह जो अगले 2 संडे है ना, इंशाल्लाह मैं आपको बीजिंग की वॉल के ऊपर बैठ के ये वेबिनार करूंगा, आपको लाइव वो भी दिखाऊंगा, चाइना वॉल भी दिखाऊंगा इंशाल्लाह। जी जी,
वेरी गुड, वेरी गुड।
जी 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 सर।
आप भी जहाँ बैठे हैं, बीजे सीनरी बड़ी खूबसूरत है, तो आप बीजिंग
ये मेरे जहाँ मैंने एज ए 3 साल प्रिंसिपल गुजारा है ना, तो वो मुझे बड़ी यादगार। जी जी, अपना सफदर मलिक साहब।
अच्छा, मैं देख रहा हूँ कुछ हमारे पार्टिसिपेंट ने मांगा हुआ है इसको लेक्चर को, तो मैं आपको अपना लेक्चर शेयर कर लूंगा, दे दूंगा।
मैं ईमेल के जरिए तो शेयर कर दूंगा, जो ईमेल आई है मैं कर दूंगा।
दिस लेक्चर इज अवेलेबल फॉर एनी पार्टिसिपेंट, इफ यू कैन हेल्प, इट विल माय प्लेजर। तो मैं आपको अपना लेक्चर पूरा व्हाट्सएप दे दूंगा।
बहुत शुक्रिया। मुझे आप ना मुझे ईमेल पे करें, आपका लेक्चर बड़ा है, ईमेल भेजूंगा मैं अपने उस पे, फिर हम ईमेल पे ही शेयर करेंगे। जज़ाकल्लाह। What do you, Professor Salma Kundi, to conclude today's session?
Okay, Ji. Thank you, Mulazim Saab. Thank you so much. I'm really, really grateful to Professor Safdar Malik Saab, our very soft-spoken senior educationist. That was a lovely lecture. अल्लाह आपको इसका अज्र खैर दे। संडे को इतना टाइम निकालना, इतना बोलना बहुत ही ज़्यादा टाइम कंज्यूमिंग होता है और कुर्बानियाँ मांगता है। And I'm also very grateful to Professor Iqbal Dogar Saab for being here with us. Paja Khurshid Saab, Tanveer Zubair Saab, Tariq Malik Saab, राशिद साहब, कैसर भाई। मैं ये आपसे अर्ज करना चाह रही थी मुलाजिम साहब कि इनमें बहुत से ऐसे लोग हैं जिनको आपने इस दफ़ा तो इनवाइट किया, बट आई डोंट हैव एक्सेस टू द ग्रुप्स जहाँ पे हम इनविटेशंस दें। तो इनके लिए प्लीज आप जरा अपने उसमें ले आए, बिकॉज दे ऑल
ईमेल करेंगे ना हम, ईमेल ग्रुप पे, अंदर ये जो अभी इनमें आज भेजा है ना, इसके ऊपर ईमेल ग्रुप के ऊपर हम इनको इनविटेशन
हाँ, ये आप ईमेल पे प्लीज बना लीजिए,
ग्रुप में भेज देंगे।
क्योंकि मैं तो व्हाट्सएप ग्रुप जो टिपिकल सोसाइटीज़ हैं, PMA है, पाकिस्तान फिजियोलॉजिकल सोसाइटी है, मेरा वुमेन मेडिकल कॉलेज का है, तो मैं उनमें डाल देती हूँ। लेकिन ये इतने अच्छे हमारे सीनियर्स हमसे फिर रह ना जाएं। एंड थैंक यू टू